Diagnosis of hemolysis begins with the direct antiglobulin test. A positive result indicates immune-mediated destruction, but non-immune hemolysis returns a negative DAT. Without antibodies tagging the cell, non-immune hemolysis requires direct environmental, biochemical, or physical damage to the red blood cell membrane. Infections serve as a primary vector for this direct damage. Pathogens like malaria, babiosis, Bartonella, and Clostridium perfringens release endotoxins and exotoxins that compromise the red blood cell in circulation. Specific drugs and toxins provide a second vector by inducing direct oxidative damage. Agents like dapsone and primaquine can trigger rapid hemolysis without involving the immune system. While infections and drugs offer straightforward diagnostic clues, two other categories, paroxysmal nocturnal hemoglobinuria and fragmentation syndromes, require deep molecular investigation. These conditions can present as a confusing array of organ failure and marrow suppression. Identifying them early is critical to preventing permanent vascular and renal damage. Hematology typically follows a clear rule. Inherited hemolytic defects are intracorpuscular, while acquired causes come from the environment outside the cell. Paroxysmal nocturnal hemoglobinuria, or PNH, is the exception. It is an acquired condition that creates an intracorpuscular defect, changing the cell from the inside out. This defect begins with a somatic mutation of the PIGA gene on the X chromosome within a hematopoietic stem cell. The mutation halts the production of glycosyl phosphatidylinositol, or GPI anchors. These are the molecular tethers that should be embedded across the red blood cell's lipid bilayer. Without these anchors, the cell cannot dock critical protective proteins. The first lost shield is CD55, also known as decay accelerating factor. The second missing protein is CD59, the membrane inhibitor of reactive lysis. Like CD55, it requires a GPI anchor to stay attached to the cell surface. Red blood cells missing these specific surface proteins are referred to as PNH3 cells. Stripped of CD55 and CD59, PNH3 cells are defenseless against the body's own complement system. This leads to uncontrolled complement-mediated lysis within the blood vessels. Clinically, PNH manifests as chronic intravascular hemolysis, punctuated by acute, severe exacerbations. The hallmark early morning dark urine occurs because sleep-induced hypoventilation causes a mild respiratory acidosis. This slight drop in pH is enough to trigger a surge of complement activation and subsequent cell destruction overnight. Centrifuging a urine sample distinguishes true hemoglobinuria from standard hematuria. While intact red blood cells settle into a pellet at the bottom, free hemoglobin remains suspended in the supernatant, leaving the fluid dark red. While the hemolysis is striking, the primary lethal threat in PNH is paradoxical thrombosis. Massive red blood cell lysis dumps free hemoglobin into the plasma. This free hemoglobin scavenges and neutralizes nitric oxide, removing the natural gas that prevents platelets from clumping and vessels from constricting. The PIGA mutation also prevents the anchoring of the urokinase plasminogen activator receptor. Without this receptor on the cell surface, the body cannot effectively break down clots in the microvasculature. These mechanisms often result in Budd-Chiari syndrome, where a clot occludes the hepatic vein, leading to rapid liver engorgement, abdominal pain, and fluid buildup. PNH is rarely limited to the red blood cells. Because the mutation occurs in a stem cell, it frequently results in trilineage pancytopenia, a shortage of red cells, white cells, and platelets. This marrow defect is often identified by a low neutrophil alkaline phosphatase score, a diagnostic marker PNH shares only with CML. The relationship between these conditions is defined by the 25-10 rule. 25% of PNH patients will develop aplastic anemia, while 10% of all aplastic anemia cases are actually PNH. Dark morning urine, hepatic vein thrombosis, and bone marrow failure trace back to the same molecular failure, the absence of the GPI anchor. Flow cytometry of peripheral blood is the gold standard for diagnosis. It provides a precise count of PNH3 cells missing CD55 and CD59 shields. A PNH diagnosis is considered clinically significant when the sample contains more than 50% PNH3 red blood cells. For severe marrow involvement, the definitive cure is an allogeneic hemopoietic stem cell transplant. When the primary issues are hemolysis and thrombosis, clinicians utilize anti-C5 monoclonal antibodies. Drugs like eculizumab and the longer-acting ravulizumab bind to the C5 complement protein, blocking the terminal cascade before it can lyse the unprotected cells. Because blocking C5 disables a key part of the immune response, patients must receive a meningococcal vaccine before treatment begins to prevent life-threatening infections. These therapies address the specific molecular deficiency, shielding the cells even when the anchors are missing. The second major category of Coombs-negative hemolysis is fragmentation, which includes microangiopathic hemolytic anemia and thrombotic microangiopathy. Fragmentation syndromes begin with acute endothelial injury in the small blood vessels. In response to injury, endothelial cells release high molecular weight von Willebrand factor multimers from their internal Weibel-Palade bodies. These multimers anchor to the vessel wall while tethering passing platelets via the GP1b9 receptor, constructing a dense physical barricade across the microvessel. When red blood cells strike this rigid platelet plug, they are physically torn apart. This creates the jagged, helmet-shaped fragments known as schistocytes. The mechanical shearing results in profound thrombocytopenia as platelets are consumed to build the plugs, and the appearance of schistocytes on the peripheral blood smear. Because these plugs are made of platelets and von Willebrand factor, the plasma clotting cascade is not involved. Consequently, PT and PTT laboratory times remain completely normal. Mechanical shearing also occurs in cardiac hemolysis due to prosthetic valves and in Casaba-Claret syndrome, where giant hemangiomas consume platelets and clotting factors. To manage microangiopathic hemolysis, clinicians must determine whether a toxin or an autoantibody is triggering the endothelial damage. Hemolytic uremic syndrome and thrombotic thrombocytopenic purpura represent the two primary clinical syndromes of microangiopathic hemolysis. HUS is defined by the triad of hemolysis, low platelets, and acute renal failure, reflecting damage localized to the renal microvasculature. Childhood, or D-positive HUS, follows a bout of bloody diarrhea. The damage is caused by bacterial toxins that destroy the endothelial lining of the kidney. The most common culprits are Shika-like toxin from E. coli 0157H7 and Shika toxin from Shigella dysenteria. Management for childhood HUS is limited to supportive care. Antibiotics are avoided as they can trigger a massive release of toxin and worsen the disease. Adult, or atypical HUS, is caused by inherited mutations that lead to dysregulation of the alternate complement pathway. Mutations in complement factor H are the most common cause. Without this regulatory protein, the complement system attacks the blood vessels, often leading to end-stage renal disease. TTP presents with the additional symptoms of high fever and neurological deficits like strokes, while typically sparing the kidneys. In TTP, acquired autoantibodies neutralize the ADAM-TS13 metalloprotease. This enzyme normally cleaves von Willebrand multimers into smaller, non-obstructive pieces. Without ADAM-TS13, the multimers grow to massive lengths, trapping platelets systemically and occluding blood flow to the brain and gastrointestinal tract. Treating TTP requires emergency plasma exchange to remove the autoantibodies and replace the missing ADAM-TS13, often combined with corticosteroids and rixatoximab. Determining whether a toxin or an autoantibody is driving the mechanical destruction is the key to selecting the correct treatment. Diagnosing DAT-negative hemolysis involves distinguishing between a biochemical defect in the cell membrane and mechanical shearing within the vasculature. A PIGA mutation creates a biochemical defect, stripping cells of the GPI anchor. This leads to complement-mediated lysis and hepatic vein thrombosis, confirmed by flow cytometry. In contrast, mechanical shearing produces schistocytes despite normal coagulation times. The specific trigger, whether bacterial toxins in the kidneys or ADTM-TS13 failure in the brain, dictates the final diagnosis of HUS or TTP. While these conditions present as complex systemic crises, they are driven by specific, identifiable molecular deficits that can be precisely addressed once the mechanism of destruction is understood.